All right, so obviously I'm talking about dry eye, and you know, I can go on about that all night, but I mostly want to focus on diagnosis and management and some of the newer stuff that's getting done. So obviously we all understand dry eye, right? You know, you've got the oil layer on top, and I'm finding that most of the dry eye that I'm dealing with is that, you know, that lipid layer deficiency. And it's funny because patients are coming in, and I'm noticing, especially with the lipid layer deficiency, they might not necessarily feel that their eyes are dry, but they've just got sort of this vague complaint of fluctuating blurry vision. And I think you've kind of got a feel a lot for what we do here. You know, we're trying to get people are paying for that 20/20 vision, right? They want to be able to see through walls. And when they're coming out and they can't, they want to know why. And so often we're finding it's a dry eye issue. I feel like the tear film probably accounts for about a half diopter of, you know, the eye's refractive index. So we've had patients come in, you know, 20/40 on the eye chart. You know, I paid for LASIK, I feel like I can't see, you know, we treat their dry eye, all of a sudden they come in for follow-up, they're 20/20. So in this practice, it absolutely makes a big difference, and hoping you find it does in yours too. The dry eye grading scale, I don't use the grading scale a whole lot, but you know, the main thing is that it is worth noting, we grade everything, right? So a level 1 dry eye, the big thing is, you know, you're not seeing a whole lot under the slit lamp, and if you'll notice these corneal findings, by the time you start noticing corneal findings, you're already at a level 2 and 3 dry eye. And dry eye is so much easier to treat when it's here, when it's a level 1 dry eye. So I just wanted to point that out. We've got all these fancy tests now. We've got the tear lab testing, the Inflammadry, which I'm going to talk about. But obviously, a lot of it, you still got to use your eyes. You've still got to look under the slit lamp. Corneal and conjunctival staining. You have to do Meibomian gland expression. You have to press on the Meibomian glands and see what's coming out of them. Diagnostic tools, I'm going to talk about the tear lab, the osmolarity testing, RPS's Inflammadry, Schirmer testing. Yes, there is still a place for that. Meibomian gland imaging, and of course the Sjogren's test. I wasn't doing a whole lot before I came to this practice, and then I realized just how much dry eye I was missing. We always hear it stains dead and devitalized cells and mucus strands. Really, that's your indicator of goblet cell loss, which again, going back to that grading scale, you start to notice that on a level 1 or 2 dry eye. It will also pick up a conjunctival chalasis for you, so it gives you that foreign body sensation, and that's actually something that Dr. Siepser can manage surgically here as well, but there is a lot of confusion between that and dry eye symptoms, so it does help you differentiate that as well. So just an example of lissamine green staining, you can see it over here on the conj, okay? So that's somebody with a level 1 or 2 dry eye, and you definitely want to start treating when it gets to that point before it makes its way onto the cornea. So again, you know, corneal staining, obviously you do fluorescein staining. Makes a big difference if you let it sit for a few minutes. You know, you can't put the stain in and look at the slit lamp. You really do have to let it sit. I've been surprised what a difference it makes just by letting it sit there for 5 minutes. Evaluate tear breakup time, obviously. Again, if you look at that SPK and it's central, already a level 2 dry eye. And then of course you want to look at where it's staining. Inferior, obviously it can be a whole number of things. You know, they could be what I call a lazy blinker. We've all seen those under the slit lamp. Exposure keratopathy is a big one. You'd be surprised how many people don't close their eyes all the way when they sleep. Ambien, I swear it leaves, you know, on the inferior, you know, probably third of the cornea, straight across from 3 to 9 o'clock. You just see this line of SPK. And if you start questioning enough, you know, you'll see that they are using a sleep aid more often than not Ambien. So important to go through that list of medications, see what else could be contributing. I had somebody, I finally figured out what was contributing to their dry eye was the placement of their TV at home. The TV was up above the fireplace mantle, and looking up at the TV was drying their eyes out all night long. So it is important to talk to people about lifestyle and figure out, of course, what else could be contributing. You can buy all of these instruments, paddles, rollers, etc. You can use Q-tips. Dr. Siepser prefers to use Q-tips to kind of, you know, press on both sides of the lid and, you know, see what comes out. It helps us figure out who's going to be successful with Meibomian gland treatment, like Lipiflow, Meibomian. I tend to just use my finger, light pressure. It's diagnostic because it's similar to blinking, and I can get a pretty good idea for what's coming out of those Meibomian glands just by pressing. And if nothing comes out, then you know that you've got to open up those Meibomian glands, which again, I'll talk about that as well. The tear lab osmolarity testing. You know, the dry eye workshop defined dry eye in part as hyperosmolarity of the tear film. You get this unit and you can actually collect tear samples, and you hold it over on the, you know, edge of the patient's eye and have them look up, and just takes a couple seconds, collects a small tear sample, and it gives you an osmolarity reading. Osmolarity is a measure of solid particles in solution. So I always say to patients, you know, our tears are essentially a combination of water and salt. 2 too much salt, not enough water, we consider those tears to be dehydrated or dry. Anything above 300 is considered to be a dry eye. Anything, when you see a difference between the two eyes, say you have, one eye that's 300, one eye that's 330. If you see a difference of greater than 8 between the two eyes, you're definitely dealing with a loss of homeostasis in the tear film, and that's somebody who has a pretty significant dry eye. Personal observation, this test does a better job at at detecting aqueous deficient dry eye than it does an evaporative lipid layer deficiency dry eye. I can't tell you how many patients I have come in where they have an absolutely normal tear lab reading, but they've got an evaporative dry eye. So again, like I said, you still have to look with your eyes under the slit lamp. This is billable to insurance. There is a code for it. You have to make sure they haven't had artificial tears for at least 15 minutes prior, and you do need a CLIA waiver, which is something I'll talk about a little bit later. So there's just a picture of collecting the tear sample. It's quick, it's painless to the patients. You do need to get a CLIA waiver if you want to do this test. You basically have to declare yourself a lab. The government decided that. If you are interested in doing any of this testing, Tear Lab or RPS, one of the companies, will basically do the legwork for you. You just sign the paperwork and send it in. It goes through the state, through the Department of Health. You have to renew it annually. Costs about $100 a year, and you have to do quality control measures, which of course they'll help train you in how to do that. So this is another example of another CLIA wave test. Basically, it's looking for MMP9, which is essentially, I wrote a whole big thing about it here. It's basically an inflammatory marker in the tear film. The tear film starts to break down, releases MMP9, and that's a pretty good indicator of inflammation. It looks like a pregnancy test. Little pink line. You've got an inflammatory type of dry eye. So personally what this helps me do is help me decide if this is a patient who would be successful with treatment with Restasis, Xiidra, a soft steroid, an anti-inflammatory, essentially, because then this is an inflammatory mediated dry eye. Just been my personal experience. I really feel like this helps kind of weed out the patients with the aqueous deficient dry eye versus a Meibomian gland dysfunction. So the Schirmer testing, yes, I do still use it. Obviously, just a quick refresher, there's 2 ways to do it: without anesthetic, with anesthetic. Without, it gives you, the baseline and the reflex secretions. I don't use this one a whole lot, but if you're sending a lot of patients to rheumatology, this is the one that they want because it's going to help them decide if this is somebody with Sjogren's syndrome or not. It's going to help them figure out how much, basically if they can produce tears and how much. I do the Schirmer too. I do it with the anesthetic. What really helps kind of pull out, make sure that you're just getting, the baseline and not the reflex tearing, is lights dim, head back, eyes closed. Make sure the paper's over here in the corners, and then that way it's not irritating the eye. Really helps to use fluorescein because then you can mark it and you can see how far they got down on the paper. So Meibomian gland imaging, you can obviously, you can get Lipiflow, you can get, the machines with the cameras that do it for you. I've had a lot of success just using a transilluminator, and we do have a patient here today that I can show this, I can demonstrate this on. You just take your transilluminator and flip the lid down and hold it up, and you get a pretty good idea of what's going on with those Meibomian glands. You can see here, this is somebody who's had a whole lot of atrophy. So when you're pressing on those oil glands and you're not seeing a whole lot come out, why? Have those Meibomian glands, have they scarred over? Is there scar tissue on top? We can treat that. Or is it true atrophy and have they actually lost Meibomian glands? It really helps you figure out who's going to be successful with treatment and who is not. So this is, formal Meibomian gland imaging with the Lipiview. You can see here, this is somebody, actually, if you look down here, so this is a good example of Meibomian gland atrophy, okay? So if you transilluminate and you see something like that, it helps you figure out how successful that patient is going to be with treatment. So the SHOW test, this helps look for Sjogren's syndrome. You used to have to write the order for blood work, right? And, these were all of the markers you were looking for. They weren't that specific. Rheumatologists practically laugh at a positive ANA. They say, most of us have it. So when you look here, these are all of the new biomarkers that the SHOW test can look for. These catch the disease pretty early in the process, and they're pretty specific for Sjogren's syndrome. Sjogren's syndrome, they estimated affects about 4 million people in the US. There's about 3 million undiagnosed, they estimate. It's one of the top 3 most common autoimmune diseases. 9 in 10 patients are women, of course. There's primary and secondary. 4.7 years average delay in diagnosis. So if you can do the show test and catch it early, you've done your patients a big, big favor. They think 1 in 10 dry eye patients has Sjogren's syndrome. So if you're not testing for it, you're missing a lot of it. Here's the big thing. Everybody says, why do I have to do this? Well, it starts to affect other organ systems. As we know, 5% of Sjogren's syndrome patients will develop lymphoma. So I always say to patients, I don't want to use this as a scare tactic, but this is one of the reasons that we test for it. Obviously, increase in depression, and like I said, the proprietary markers are more specific for catching the disease early. Who to test? Anybody with dry mouth, history or family history of autoimmune disorders. It affects women more than men. Recalcitrant dry eye, and I've found patients with a really high tear lab score. That's somebody who you have to test, because more often than not, you're getting a positive show test back. So here's what it looks like. You can do it in the office with a finger prick test. You actually don't bill for it, because you basically are just collecting the tear sample. You don't need a CLIA waiver to do this one, and then sending it off to the lab, and then the lab is doing the testing. So the lab handles all of the billing and the insurance and everything. But you can also just order it through LabCorp or Quest. If you do want to get set up with the test, Bausch & Lomb has the show test, and they can help you get your script pads and everything to start doing the show test. So that's the way we do it. It's just a lot faster and more efficient to send the patients out to get the lab work done for that. So if you do get somebody with a positive show test, basically you've got to send them to a rheumatologist. I don't know if you guys have any experience with rheumatology. It is not all created equal. Some rheumatologists you're going to send this to, and there's going to be a positive show test. They're going to blow it off. Others are really going to do an in-depth workup. I refer a lot to the Sjogren's Center down at Penn, Dr. Frederick Bravino. He's wonderful. Most patients you're going to find when this comes back positive, they're willing to wait. It's about a 6-month wait to get into Penn. If you have anybody locally, who does have a positive show test, you want the names of some other rheumatologists who are a little bit more local and they can get in with a little bit quicker, who I have found do take a positive show test more seriously. So treatment, okay, we're going to go through just, most of this. With an aqueous deficient dry eye, obviously, Restasis, we all know. 2 times a day, both eyes, preservative free. I think most of us probably are starting with Lotemax to get patients that instant relief, since the Restasis does take that full 3 to 6 months to really ramp up. What I found interesting that I didn't know is that Restasis actually increases goblet cell density, which is pretty cool. So again, going back to those level 1 or 2 dry eye patients, if you can start them when they're a level 1 or 2 dry eye, they're going to be much more successful in the long run. And all of your Restasis patients probably ask you about punctal plugs, right? They read the package insert and they say, well, I thought I couldn't do this. It just wasn't in the original study design. They just didn't do the original study with the punctal plugs and the Restasis. So that's all that means. Everybody wants to know, is it safe? At 12 months, there was no quantifiable levels found in bloodstream. Like I said, the best results happen when you've got a level 1 or 2 dry eye. For coding, you get a lot of rejections if you don't code K-SICA. So just, if you're using Restasis, use that K-SICA code. You're going to save yourself a lot of headaches that way. So Xiidra. I don't know if it's because we're a surgical practice and we're getting patients with pretty significant dry eye. Their eyes are raw. They're coming out of surgery. I haven't had a great chance to really, assess its efficacy. The patients who have come back using it, I do think it works. I haven't been able to get past this with, patients come back saying it's stinging, it's blurring their vision, it leaves a funny taste in their mouth. So the patients I've seen use it, I think it works. I've got a lot of patients in here who can't get over the stinging, who just come back. They don't have the patience to get through that original hump. But again, works similar to Restasis, cell blocker. So the Re-esterified omega-3s. There's a big difference between an ethyl ester omega-3 and a triglyceride omega-3. The over-the-counters are all going to be ethyl ester, and that means that basically it's in an alcohol form. It's got to get processed through your liver, and by the time by the time that omega-3 finally reaches your bloodstream, it's so diluted, it's not doing much for you. It's not getting you. They consider 8% or higher to be a therapeutic blood saturation level. And the ethyl ester omega-3s aren't going to get you to that therapeutic level. They also have that whole big list of scary side effects that patients are always asking you about. So if they want therapeutic benefits and a safe one, they've got to do a re-esterified triglyceride form omega-3. And they've got, the studies to back it up. So they found that a re-esterified omega-3, it'll decrease the tear osmolarity. It actually has increased the TBUT. You can see, it's not significant, but they've proven it in studies. It improves Meibomian gland secretions. So it gets you, and all of off some pictures a little bit later on. It gets you from, if you ever press on the oil glands and you see like that toothpaste secretion coming out, it's one of the ways it helps your patients get back to that nice, clear, healthy oil coming out of those oil glands. It's also a potent anti-inflammatory, so in a roundabout way, that's how it helps with the aqueous deficient inflammatory dry eyes as well. I've had significant improvement in my patients' tear film just from doing this alone, which of course you want to do it in combination with other therapies. If you work with PRN at all, they're one of the 3 brands that does a re-esterified omega-3. Don't forget to tell your patients that there is vitamin D in it. There is such a thing as vitamin D toxicity, and so many, especially of the elderly patients, are taking a vitamin D supplement. So you do want to be really careful, you know, with just cautioning them about that. The way that specifically the PRN brand is prescribed is it's 2 capsules twice a day. And everybody says, can I just eat more salmon? Well, no, you'd have to eat 37 cans of tuna to get to that therapeutic level. So no, so that doesn't work. Patients end up kind of married, I found, to their brand of omega-3. The nice part about, you know, if you do choose to go with a company like PRN is a lot of them have health coaches that can talk to the patient, so you don't get stuck in the room talking about omega-3s all day long. You know, they say, do I have to take 4 pills? Yes, that's what gets you to the therapeutic level. And again, like I said, just caution them about vitamin D toxicity. Lacrosert, I haven't had great success with it. It's a good idea in theory. Basically, it's just this little insert you can see down here. You put it in, you know, in the inferior cul-de-sac out, you know, in the temporal corner, and you wait for it to dissolve. Patients with a pretty significant dry eye, I found it's just not dissolving. So it's a good idea in theory. I have had some patients who have had some success out of it. You know, it's basically supposed to be a slow release artificial tear. But like I said, for somebody with a really significant dry eye, it's just, personally I have found it's not dissolving like it should. Nighttime ointment or Liquigel, obviously this is great for your exposure keratitis patients, anybody with inferior corneal staining. I don't know if you guys do the trick, you know, with your patients, you have them tilt their head back, close their eyes, and look for that little bit of glistening down there. If you see that little bit of glistening, you know that eye's not closing all the way when they sleep, and that's somebody with an exposure keratitis. You know, definitely nighttime ointment. Liquigel, if it's, you know, if they can't tolerate the thickness of an ointment, patients don't like that blur when they wake up in the morning. I talked about this before, just ask about medications. This is something that's really, you see this a lot in your CPAP patients with sleep apnea. They're getting the drying effect from the oxygen all night. Another thing you can do at night is these eye seals. They're pretty cool. I just tend to be partial to this company's goggles. You know, it's for somebody with real bad exposure keratitis, just to help get you that corneal coverage all night long. You know, there's a coupon code. It donates to the Sjogren Syndrome Foundation. Punctal plugs. Going back to the Inflammadry testing, I found it's best to wait until the Inflammadry is negative, because it doesn't make too much sense to put punctal plugs in an eye that still has a whole lot of inflammation in it, and then you're basically just keeping inflamed tears on those eyes. So I like to, you know, do the Restasis, do the Xiidra, the Lotamax, what have you, get the inflammation down, get a negative Inflammadry test. You will see, by the way, you will see the Inflammadry test change from, you know, one visit to the next with patients. Sometimes you get positive, sometimes you get negative. But I like to wait till it's negative before I go to the punctal plugs. Order more smalls and extra smalls than you think you need. I'm finding most people do fall into that small category. Autologous eye drops, or serum eye drops. I feel like it's one of these things you always hear about at lectures, but then don't know how to do it practically. So they're preservative-free artificial tears made from a patient's own blood serum. Our own tears contain epithelial growth factor, and you can see, you know, vitamin A, all sorts of other things that really help keep that epithelial surface healthy. So if you do end up prescribing this, you do have to send somebody out for a plasma blood draw, and they have to actually, you know, centrifuge it, take the plasma out, and then that's actually what they make the patient's own artificial tears from. So you have to say how much of the patient's plasma you want in it. So I prescribe at 50% 4 times a day. Start with a 6-month supply. Why 50%? Because they do it based on the concentration of transforming growth factor beta 1. And that actually inhibits epithelial proliferation. It's in the serum, it's 5 times higher than it is in the tears. If you choose to do it, you can do it at 20%. It keeps that beta 1 low, but it's at the expense of other beneficial growth factors. If you do 100%, you run into a whole bunch of problems, and that alters the osmolality and pH of the preparation. I've only had to consider this maybe a handful of times. This is somebody who who just is recalcitrant to other forms of therapy. And I should say, as I'm going through this, I'm kind of, starting with, the least severe patient and going down to that level 4 dry eye where it's just diffuse SPK. You've tried everything. That epithelium is just raw. And, also if patients are a little motivated, because we're talking, it is about $555, if you go through this company Novatiers for a 6-month supply. So basically it's the recalcitrant dry eye patients. And, I've had patients, it's funny, who aren't at that level 4, but they're asking, what else can I do? What else can I do? Well, you can try Autologous Serum eye drops. It's a little bit of a process, but hey, go for it. I've just found the easiest way to do it is to go through this Novatiers company. You go online and you basically fax a prescription to Novatiers, and then they send the patient the kit, and then the patient can go someplace like in any lab test now for the blood draw. Because the biggest thing is you need a sterile pharmacy in order to do this, which I didn't know. And there's very few pharmacies out there that are a certified sterile pharmacy. So I found, rather than just spinning your wheels, the easiest thing to do is just fax the prescription to Novatiers, and then they take care of the rest for you. Patients still need to be careful about not contaminating the unfrozen tears. They can't be unfrozen for longer than a week, but again, that's all going to be in the patient information packet that they get. Amniotic membranes. Dr. Siepser actually does a lot of the amniotic membranes here. We mostly save it for our ABMD patients. It does certainly help with dry eye, but we're doing, he does a lot of PTK first on those patients with the ABMD, which can be confused with dry eye a lot, and then doing the amniotic membrane on top. But you can do it also, you can see it's got all these indications: corneal abrasions, corneal ulcers for faster healing. Again, personally, before I would consider this for a dry eye patient, I'm kind of trying everything else first before I get to these level 3 and 4 dry eye patients. Most of the amniotic membranes will disintegrate on their own. You can get freeze-dried and dehydrated membrane. Those you can store at room temperature. You need to place a soft contact lens on top of those, and you do have to remove the contact lens eventually. The cryopreserved, like the Procaras, which I know a lot of ODs are doing mostly, you have to keep those frozen at -80 degrees. They come in the contact lens with a ring around them, and then the ring does have to eventually be removed, and obviously these are well reimbursed, which is a good impetus to do them. Scleral lenses, you can just see here, here's a patient with a pretty raw dry eye, and then you fit them with a scleral lens, and just by having that reservoir filled and getting the liquid on the eye all day long, patients have had success with that. So it's just another option in your dry eye treatment regimen. I covered this, the aqueous deficient dry eye, evaporative dry eye. So Lipiflow, you can see here, okay, it's basically heating up those oil glands for when the oil glands get backed up with those really, significant Meibomian gland deficiencies. You have to remember the melting point of meibum is 104 degrees. That's why a lot of patients don't have a whole lot of success using just warm compresses at home. So, any of these treatments, you do have to repeat them yearly. A lot of offices are doing 3 treatments. What's kept a lot of, practices, I think, from buying the unit is that it's pretty expensive. Lipiflow, I know the cost to the patient's about $1,700, so it is a pretty costly treatment. You can see here what the Lipiflow does is they have the pad on the outside, the pad on the inside, and they massage the lid, and then obviously heats up those Meibomian glands, and then with the massage also it helps get the worst of that clogging out. We do something here called Meibomian. We found that was a much better fit for our practice. Meibomian, it doesn't have the heating pads on the inside of the lid, it's just on the outside, because your globe provides a lot of the resistance that you need. We found that you don't really necessarily need to press from inside and outside, because your globe's providing a lot of the resistance from the inside of the eyelid. You can repeat it yearly to every 24 months. The Meibomian heats up to 108 degrees. I've had it done myself. It does not hurt. So the Meibomian is 3 treatments. You come in, it's 12 minutes per eye for the first treatment. You wait a week. It's 10 minutes per eye for the next treatment. You wait 2 weeks. 8 minutes per eye for the third treatment. You wait 4 weeks, and then a follow-up visit with me. And we found that there's a big wow factor after the first treatment, and then patients actually still continue to obtain added relief after, in the first few months initially after the treatment. A lot of patients need Meibomian gland puncture first, which is something that Dr. Siepser does. Again, it goes back to that Meibomian gland imaging. You can see here, these are Meibomian glands that have not been punctured. These are Meibomian glands that have been punctured. So if you're pressing on the oil glands and not getting a whole lot out, they could just simply need Meibomian gland puncture, which is something that Laura had done. So she'll be able to talk to you a little bit about that as well. Tea tree oil, you guys prescribing tea tree oil for your patients for the Demodex, okay? Only thing that kills the Demodex. There's the Blefadex wipes, the Clearadex wipes that the patients can all do at home. I do an in-office treatment here with swab sticks that have the tea tree oil in them. I'm finding that you need to treat patients probably about every 3 months, and then after about 2 years of that, they start coming in, and I don't need to treat them as frequently, which is pretty cool. I don't use the Blefex here, but that's just another option for an in-office treatment. You can get a training course for that. Again, every 4 to 6 months, you can see the unit here, just clean the eyelids off with that. You can treat, obviously, Meibomian gland dysfunction with oral medications, doxycycline, azithromycin. A 2015 study showed that compared to 2 months, the percentage of clinical improvement was significantly better with the Z-Pak group, basically. So that's another option. Re-esterified omega-3s, like I talked about, that's just another way to improve the Meibomian gland secretions. So Avenova, you heard Dr. Siepser talk a little bit about that. It's got the hypochlorous acid in it. Hypochlorous acid is the only thing that not only kills the bacteria that chronically colonizes the eyelids, but it also kills the biofilm. So if patients are doing over-the-counter lid scrubs anyway, why not try something prescription strength? There's 2 different ways to make hypochlorous acid. Nutrox, which is Avenova, their process, you come out with pure hypochlorous acid. You'll find that other companies are using a process where basically you can see they're coming out with bleach. So that's the difference between Avenovas and a lot of the other products. I think, the AccuSoft has the hypochlor. I started to get prescription rejections for Avenova because they're trying to substitute it with other prescription products that have this microcin in it. Again, you can see the percentage of bleach essentially that comes out from their process. The Meibomian, the Avenova, and the omega-3s, the 3 of them together. Huge. That's what, and that I always say the Avenova and the omega-3s, that's what helps them maintain the results that they just paid to get through Meibomian. Yep. And you can help stretch it out to 1 to 2 years that way. And of course, obviously, if they're getting a solution with bleach in it, bleach does not penetrate through the bacteria, the biofilms, and the spores the same way that Avenova, the pure hypochlorous acid does. Azisite, I don't know if you guys have had much success with that. I found that if you prescribe Azisite for a month, it's helped with patients who have had lash loss. That's just sort of an anecdotal thing for me. You're just making use of the anti-inflammatory properties from Azisite as opposed to, the bacterial or antibacterial properties of it. And then finally, sometimes you just get a dry eye patient who you've thrown everything at them and they're just not happy. There is such a thing as neuropathic eye pain. Those patients actually do, they need to see a pain management specialist, and I've had to do this with a couple of patients. Risk factors for this, non-ocular risk factors, sleep disturbances, sleep apnea, insomnia, psychiatric conditions, post-traumatic stress disorder. So these are patients, you don't want to just keep spinning your wheels, keep trying to manage that. Refer them out to a pain management specialist is, bottom line. They have actually done some studies where they've shown that patients have increased serotonin levels in their tears, which would increase pain sensation. In theory, you should be able to treat that with mast cell stabilizers. Hasn't been my clinical experience. Again, if you have a dry eye patient, ocular surface looks great, something's not adding up, the testing looks good, something to consider, and those patients are usually more than willing to get a referral.